Good evening. Welcome to the October 2016 meeting of the Los Angeles City Health Commission. My name is Matthew Sharp. I'm the Vice Chair of the Commission and just spoke with the Chair, Ms. Shannon, who's on her way and encourages us in respect for everyone's time to get going with this evening's proceedings. She'll be here momentarily. So I think our first order of business is roll call. Ms. Clerk, please take the roll.
Ariola.
Here.
Avila.
Here.
Braun.
Here.
Hisrich.
Here.
Hawkes. Here. Jimenez.
Here.
Cotto.
Here.
Mandel.
Present.
And Sharp.
Present.
9 members present.
I think our first approval of the September 12th, 2016 minutes is the next agenda item.
So moved.
Second.
All in favor?
Aye.
Any abstentions? Objections? If none, so passed. The next item is to ensure that any members of neighborhood councils that are present on behalf of their neighborhood council have an opportunity to speak at the beginning of the agenda. It's a new and important city procedure to acknowledge the 96 neighborhood councils and thousands of Angelinos that are participating in that process. So if you're here from a neighborhood council, this is the point in time when you are invited to address the Health Commission on matters underneath the jurisdiction and regarding health. If there are no representatives of the neighborhood council,
No. No, I didn't get any information before that.
agenda item number 1.
That's what the lady said.
Presentations on health-related costs, programs, and policies. We have with us the esteemed Dr. Kathleen Ruchalski, Assistant Professor of Radiology at UCLA, who's here to bring to us information regarding the importance of lung cancer screening accessibility in our community. I believe there's a presentation deck queued up for you if you would be so kind as to both introduce yourself and enlighten us. Thank you for joining us.
I'd like to thank the Health Commission for inviting me today. My name is Kathleen Ruchalski. I'm an assistant professor. Can you hear me now? Is that good? Okay. I'm an assistant professor at UCLA and a radiologist, and I come to bring you information about lung cancer screening and the importance of its implementation within the city of Los Angeles. So I'd like to first touch upon what about lung cancer. And so lung cancer is the most common cancer killer globally. And in the United States, lung cancer kills more people than the other top 4 cancer killers combined, and that meaning breast, prostate, colon, and pancreatic carcinoma. And the majority of lung cancers are related to cigarette smoking, with approximately 90% of cases being accounted for or being at part related to cigarette smoking. And the 5-year survival for lung cancer is very dismal, and so we can see that only about 17% of patients, once they have a diagnosis of lung cancer, will actually survive for the next 5 years. And so why is that? Well, the majority of lung cancers that are diagnosed are unfortunately diagnosed at a late stage, meaning that tumors are diagnosed after they've left the lung and have deposited into lymph nodes in the chest or elsewhere in other organs in the body. And so we can see here that once the tumor has left the lung and has gone to elsewhere in the body, 5-year survival decreases to 4%. But if we can catch lung cancer early when it's still only a focal lesion in the lung, survival drastically increases with a 5-year survival of 55%. So this is where the idea of lung cancer screening becomes very important, because if we can catch these tumors early through a screening process, patients are more likely to survive. So what is screening? So screening is essentially doing a test in ostensibly healthy patients to hopefully catch a disease early enough in a treatable state so that patients can therefore go on to live a healthy life. So there's been lots of tests looking at ways to perform lung cancer screening, and most notably in 2002, the National Cancer Institute launched a large randomized clinical trial, a multi-institutional clinical trial termed the NLST, or the National Lung Screening Trial. And their main goal was to see if screening with a chest CT annually for lung cancer can improve lung cancer-related mortality. So what did they find? Well, they found that by doing a chest CT every year, they were able to detect more lung cancers than with a chest X-ray, which we would suspect because chest X-ray has already been shown to not be a very good method as a screening technique for lung cancer. There was improved lung cancer-related survival and overall survival, with a 20% increase in lung cancer, or a 20% decrease in lung cancer mortality with lung cancer screening, and a 6.7% overall improved mortality with screening. And we saw, interestingly, a stage shift, meaning that as we did annual screening, we were able to catch those tumors early. And so when patients underwent further imaging later on, we weren't finding tumors that have left the lung and had metastasized because we have caught them early and treated them appropriately. And with screening, in most patients, there are very few complications. So we can see down here, this is essentially what a screening lung chest CT looks like. And we can see here's our heart, these are our lungs, here's our thoracic vertebral body, and down here was a chest CT detected lung cancer that was able to be resected. So after the NLST results were published, the USPSTF deemed lung cancer screening a grade B recommendation, meaning that private insurers must cover screening as of 2015. And similarly, the Centers of Medicare and Medicaid Services also allowed their patients to undergo screening as well. And so mainly screening is performed in patients with very high risk, meaning that they fall within an age range of 55 to 80 years of age and have a very heavy smoking history, meaning approximately two packs of cigarettes a day or a 30-pack year history. So similarly, lots of medical professional societies have also supported lung cancer screening, including the American Cancer Society, the National Comprehensive Cancer Network. So what does this really mean for us? What does this mean for us as a community? Well, in 2010, the Office of Health Assessment and Epidemiology for the County of Los Angeles created and performed an LA County health survey, and they found that approximately 14% of people that live in LA County are active smokers. They then stratified those numbers down to a city level, and they found that the city of Los Angeles had one of the highest rates of smoking within the county. And there's a large range, obviously, so there range between 9% to 19% of people based on city council district, but on average, about 15% of people that live in the city of Los Angeles are active smokers, which equates to about 434,000 people. And then when they looked at the number of smokers within the city of Los Angeles compared to the rest of the people that live in the county of Los Angeles, they found that the city of Los Angeles fell in the third and fourth quartile, so in the higher ranks of people that smoke. So I work at an academic institution, so I can tell you how we're implementing lung cancer screening from an academic community. So we have a lung cancer screening program at UCLA, and we are continuing to find ways to better implement it. It's a multidisciplinary approach, meaning it's not just radiologists reading CT scans, but we work very closely with pulmonologists who follow nodules that have been detected but are either indeterminate for if they're cancer or not, or to help further work up nodules that are suspicious for cancer. We work very closely with our thoracic surgeon and with our pathologist. This is a program, so it's not just tumor detection. Patients have to meet with a provider first and have a shared decision-making to understand that they're entering a program and not just getting a CT performed. They have to be willing to have annual screening and follow up with their primary care physician or the provider that is following their nodules. They have to understand that if they enroll in the program, that there is a chance that they may have a false positive, and they may have a diagnosis of a nodule that's indeterminate and may have to undergo further evaluation. As we talked about, smoking is the #1 cause of lung cancer, and even CMS requires smoking cessation programs to be an active part of a lung cancer screening program. And nodules must be followed, and patients must be followed as well. So if they have an abnormality found, that we assure that they come back for further evaluation. Since USPSTF has released their grade B recommendation, our numbers have continually increased. This is an old slide, but approximately at this point, we're performing between 60 and 70 lung cancer screening exams each month. Across town, USC is similarly building their lung cancer screening program. They've also reached out to the Care Clinic in Koreatown, and they have a grant where they're able to perform free of cost or through a grant at least 100 screening examinations for those patients at Keck on weekends. Dr. Christopher Lee there has also been awarded a grant through the California Community Foundation and has been screening members of the underserved communities in the Centinela Valley. And similarly, what about our county patients? Well, the Los Angeles County Department of Health Services understands that lung cancer screening is important and that their patients too should have the ability to have lung cancer screening performed, and so a task force has been created to find ways to best implement lung cancer screening at the county level. But like all screening methods in healthcare, in the healthcare that we provide, there are a number of barriers. There are competing demands for healthcare funds. There are competing demands on the primary care physicians, which are our #1 referrers. And studies have shown that there's a lack of infrastructure or multidisciplinary personnel. A study showed that a group of pulmonologists in the VA system, when polled, said that they were really lacking infrastructure or the ability to form a multidisciplinary screening program. And this is the reason that I really bring this to the Health Commission is we are implementing lung cancer screening in our community now, but I think it's important that as these are new programs that we find ways as a community to make sure that all of our members have equal access to these programs. So similarly, the LA County Health Survey looked at smoking disparities, and they found that men were more likely to smoke than women, and African Americans were 25% more likely to be smokers than their other racial and ethnic groups. People with higher income and college education were less likely to smoke. And similarly, there are disparities with the risk of lung cancer itself. African Americans are 35 to 47% have 35 to 40% higher observed rates of lung cancer, and while they are 25% more likely to smoke, they tend to smoke less per day than other racial and ethnic groups. So there's something else there aside from just smoking that increases the risk of lung cancer. Hispanics and Asian Americans, when accounting for the amount of cigarettes that they smoke, range 10 to 20% below the predicted level of lung cancer risk. And similarly, there's disparities in resources, in the utilization of resources. The National Health Interview Survey in 2005 found Black and Hispanic smokers less likely than whites to receive and use tobacco cessation interventions. So as we build programs in our own community, this needs to be a healthcare community effort, and we need to focus on outreach. We have talked within our own radiology department that it's very difficult to expect patients from different backgrounds to come into Westwood and pay $16 for parking and to come get a chest CT. So patients are more comfortable visiting their own local health clinics, seeing the physicians that they're comfortable with, and having imaging facilities in their own communities. Breast cancer screening and mammography has really done well with using mobile imaging services, and there's been talk within the lung cancer screening realm as well that maybe this could be a potential use. And only at that point, when abnormalities are found, that maybe we should consider having central referral for further treatment. So like I said, a multidisciplinary approach. This is everyone at UCLA that's involved in our program, and I just want to thank you for your time.
Thank you, Dr. Ruchowski. Appreciate if you would be available for a minute to engage with commissioners if folks have any questions. Commissioners? Dr. Mandel.
Thank you for a great overview. I actually have a few. Firstly, is you mentioned false positivity. Can you tell us the percentage of false positivity in your study?
So the NLST found about a 24% rate of false positives. Most of those nodules were very small in size. We now have managed screening guidelines based on nodule size, and those nodules the majority of those nodules that were small that related in false positives are no longer considered actionable. So those nodules would then go back to annual screening. So the studies have found that those nodules the majority of those nodules that were false positives never became cancers, and that's because they're about 4 to 6 millimeters in size. They're very small, and so those ones now only go back to annual screening.
So how many false positives end up with either a bronchoscopy or a microinvasive surgical procedure?
That I'm not sure how many actually ended up going on for a procedure. The rate of procedure complications, both in the NLST trial as well as within another trial in Europe, was only about 1.6%. So even if patients did end up going on for a further evaluation, there's very low complication risk.
What's the cost of screening per patient?
So the cost for screening is based on CMS. I believe it's about $300 per scan at this point.
Well, that's what's billed. The question is, what's the true cost?
That I'm not sure.
Right. And the other question is, you mentioned that basically fall into the category of patients who would be screened are people who have either 30-pack year history or 2 packs a day for a period of time. You also mentioned that the African American population is more sensitive and develop cancers even with less exposure. So do you have a breakdown at all of what that population would be if they had a 25 or 22-pack year history?
So there's been several studies that have actually went back and have looked at cohorts of screened patients to figure out if the threshold of having a 30-pack year smoking history is the appropriate threshold, and the answer is no. So it's what was done in the study and what USPSTF and CMS used as eligibility criteria, just based that's what we have actual data on at this point. But retrospective data have shown that people that have smoking history of between 20 and 30-pack year smoking history may also be at risk for cancer. Studies have shown that the NLST criteria only really catches approximately 24% of people that end up getting lung cancer. So there's a large population of people that are still at risk for lung cancer that we don't quite understand how to best decide what eligibility criteria should be, and there's lots of work going on about that right now.
Because one can make an argument then for certain racial populations, they should use a different cutoff.
Yes.
And we would include in the population people who are at higher risk for other reasons, whether it's genetic, family history, or racial differences.
Yes, and there's been several predictive models that have been created. I'm not sure if ethnicity has been part of them. A lot of them have been based on nodule size and gender and other risk factors such as smoking and environmental exposures.
And the last one, I don't know if you have the data, but you showed us excellent data about smokers in LA City. Do you have data on people with 30-pack year history?
Don't.
So we don't know what percentage of the population.
That would be great information to have. Who in the city of Los Angeles actually meets screening criteria?
Right, because that would be the end that we really want to know, so we could see how successful we are to get you people to screen.
Yes.
Great. Thank you very much for your time.
Thank you.
Commissioner Hisrick?
Excuse me. Yes, John Hisrick. Given the cost of this, now, how does the screening work? Is this referrals from primary care physicians or nurse practitioners, as the case may be, to get folks that fit the criteria to then go into to the CT scan?
We get referrals from many different avenues. So we have referrals from primary care physicians. We also have referrals from pulmonologists. I think it just depends on where the patient learns about the opportunity for lung cancer screening and finds out more about the program.
So it isn't screening in the sense of just driving a truck into the neighborhood and saying, if you're over 65 and a smoker, come on in. It's got to be a referral.
Yeah, it has to be a referral, and I think one of the most important parts of the screening program that is easy to forget is the shared decision-making process, that these patients have to understand that there is a chance that there will be an abnormality found, and that they have to be willing and are healthy enough to undergo further evaluation, whether that means undergoing a procedure for tissue diagnosis or undergoing curative resection. So there's that understanding then as well that it's a screening program, and so once you're enrolled, you come for your baseline chest CT, and then most patients will then go on to have an annual chest CT, kind of like you would get an annual mammography, a mammogram. But some patients will have an abnormality and require additional workup. Most patients that have an abnormality and require an additional workup, that additional workup is an additional chest CT. So the main risk of having that is radiation exposure.
And given the age group of the folks that are targeted, how many years do you buy back in the aggregate? I mean, how many 80-year-olds, and I'm close to that, so I'm sensitive to it, but how many of them are going to, last very long after you go through all this effort?
I think that's also part of the shared decision-making process. Is this screening right for you? Is this something that you think that you're really going to benefit from?
Thank you.
Hi, I'm Andy Jimenez. I just had a question about following up on that radiation exposure. CT scans of the chest have a significant radiation exposure. I know the screening exams have a little bit less because you don't cut as finely. But what is the cumulative kind of radiation exposure after a number of years and the risk of secondary cancers from radiation?
That's a great question. And I think it's a concern both in the community as well as within the radiology community, and something that we spend a lot of time talking about. So it is a low dose chest CT that's used for screening. And so the dose is about 8 times less than a regular chest CT. And so the radiation exposure is similar to so one low-dose chest CT is about equivalent to background radiation exposure at sea level. So it's a very low dose. But but what we are also concerned about as a medical community is the additive dose over years. Yes, and that we're not sure what that could mean. But it is a good point, and we hope by continuing to do low-dose scanning and with future advances within the technology we have, I think that there's a lot of promising work going on to further lower those risks.
So 50%, unfortunately, of lung cancers in women are non-smoking lung cancers. Do you have any screening recommendations or research that you're doing to look at that population?
So I have seen several RFAs available within the research community, kind of really focusing on lung cancer initiatives in women, and I think it'll really come down to, I think there's a lot of work not just on imaging screening, but also doing more blood tests or nasal epithelial tests, or looking more at the genetic level for genetic predictors of lung cancer. And so I've been seeing a lot of work, and initiative within that area, particularly in women.
It seems that this is John Braun. It seems to me that the opportunity from the city side is to wrap this in a way that goes with other sorts of public awareness programs that we might have. There's a narrow group of people that would benefit from this, but they would very much benefit from it. Are you aware of examples elsewhere in the country where this or other concerns were wrapped together so that, like for a site or a resource, that you could find out what your risk is and where the resources might be? Like, some people it might be a breast cancer concern, others a lung cancer concern. If there were tools that would somebody visit there, there'd be a decent chance that there'd be something of value to them, even if it wasn't specifically lung cancer. Are you aware of examples of awareness campaigns that have been done that have been
I don't, and unfortunately lung cancer has a lot of stigma to it. So because it's so closely associated with smoking, a lot of smokers have that stigma of, I did this to myself. And so there needs to be a separation from smoking, from the connotation of smoking and what that means for an individual health level as well as for an economic, health level in our community, and focusing on separating that stigma that smokers have with their risk of lung cancer and letting them realize that we have resources for you. And, even if it's screening, we also have resources for smoking cessation, and the combination has been very effective. One study has shown that having a positive lung cancer screening test was a very effective way of patients actually going on to have smoking cessation. Again, those were false positives for the most part, hopefully, from what we've seen. But it was what they called a teaching moment, or an opportunity where people woke up and realized, oh my gosh, I'm going to actually quit smoking this time.
Well, that would fall into the category. That would be analogous to obesity metabolic syndrome, where there's a lot of the sense that people have brought that on themselves, but
Exactly.
but there's a more sophisticated way to approach it, so which would be analogous.
Yeah, I think breast imaging and breast cancer awareness has been a great model, and they've done a lot of great work to bring awareness into the community and create outreach, and that they would be a great program to sort of follow step behind.
Regarding breast cancer awareness issue, I know there's one of the major issues is the lack of access to mammograms and also the ability to afford a mammogram. I currently work for Ultimate, and we're doing a fundraiser just so we can provide more mammograms to our communities, are predominantly underserved. What is UCLA doing, or what are the access points that you're utilizing to offer the mammograms to those who normally couldn't qualify?
I wish I could answer that question for you. I'm not a mammographer. I'm a subspecialized thoracic and oncologic imager, so I'm kind of separate from the breast cancer screening. But if I'd be happy to send you an email or find that information for you.
Okay, any other questions? Okay, thank you so much for coming.
Thank you.
Thank you for coming.
Okay, we'll move on to our next presentation. Oh, I'm sorry. No. This is still item number 1. Okay, our next presentation is by Dr. Sabrina Friedman, who's the clinical director for the Union Rescue Mission School of Nursing Health Center at the Union Rescue Mission, and Dr. Suzette Cardin, who is administrative faculty director and adjunct associate professor at Union Rescue Mission. Thank you.
Okay, why Dr. Friedman is setting up, first of all, we are delighted to be here, and we just want to share with you what we are doing through the School of Nursing, a nurse-run clinic.
Can you speak into the microphone?
It's not working. Hello? It's not working. That's why I stepped.
I think it's working.
Is it working now? Yes. Okay, great. Okay. So Dr. Friedman is going to share with you what really happens down at the center we have at the Union Rescue Mission. We've been down there for 33 years now on Skid Row, and it's at 545 San Pedro Boulevard, right where the Union Rescue Mission is. So we're right in the center of all the action, as so the saying may go, as it relates to Skid Row and what's going on. Myself, personally, I have been involved with the clinic for the past 20 years. So 20 years ago, when I first started going down there was all men that were housed there and needed health care. And then 10 years ago, there was women who were housed there and needed health care, and now there's families. So Dr. Friedman is going to share with you what services we provide and what direction we see ourselves going in, as well as the barriers to providing a really full, comprehensive type of health care to these people down within the Union Rescue Mission area. So,
okay, good evening. One unique aspect of our clinic is that we are actually housed in the mission on the second floor. So we're not separate from the mission. We're not just on the street. We're actually inside of that particular mission. This is our mission statement. I won't read all that to you. But, our commitment is to the homeless and the marginalized. So how did we get started? I think Dr. Carden just gave you a little overview, but in 1983, the mission contacted UCLA School of Nursing, to ask if they'd be interested in having services at the mission. First, the clinic was only open 2 afternoons for 4 hours, and today we're the oldest nurse-run clinic in the country that serves women, men, and children. And we are still the only mission downtown that serves women and children as families, or dads with children are able to stay there. Okay. These are our clinic hours. They vary a little bit. That's based on the providers that we have on staff right now. We do open at 7:30 because the children are off to school around 7:30, 8 o'clock, and that allows us to, if there's a sick child before school, we can possibly see them. We can re-TB test before they're off to school if necessary, or if someone does have a job away from the mission, they can be seen. We've extended the hours so that we are there till 6 o'clock several evenings, and we have what's called nurse night hours now on Tuesdays and Wednesdays from 4 to 8. The night clinic is held upstairs on the 4th floor on the women and children's floor, or family floor. So what that service offers is that we can see the children once they get home from school, if they're ill. That family care is really important because a mom that has 2, 3, 4 kids really can't go out for the urgent care in the evening or to go to the pharmacy in the evening. So we offer that service so that at least a couple of nights a week, and we'd like to expand that as time goes on, so that they are able to be seen in the clinic without having to leave the premises after dark. So what are the services that we provide? We provide physical assessments to the men, women, and children. We diagnose and treat acute and chronic illnesses. So we see, of course, a lot of patients with diabetes, cardiovascular disease, COPD. We provide medications. Besides writing prescriptions, we also have a small dispensary which allows us to offer some of the basic medications for different disease processes to the patients, so that if they don't have insurance, we can hopefully provide those antibiotics or start them on medications. Some patients are waiting for their Medi-Cal to come into effect so that we can start their medications for them ahead of time. Or if they don't have coverage, we can do that. And it's especially helpful in that night clinic because we're all able to provide antibiotics, Benadryl, other cough and cold medicines for those children and families, so that, again, they don't have to leave to go to Walgreens or Rite Aid, which are about 5 blocks away. We provide immunizations for the children, limited for the adults, but mainly for the children. And we have the flu vaccine, which we'll be giving for the children and for the adults if needed. We do limited diagnostic testing in-house. So we have the capability to look at hemoglobin A1Cs, pregnancy tests, rapid strep, basic CBC, looking at kidney, liver function. Anything else, we do have a contract with Quest, so we're able to send out for other testing for the patients. So if they have insurance, we're able to have it go with their insurance. So that's a good service for them. So they don't have to go to Quest Diagnostics and get their labs drawn. So even if it's something we don't do in-house, we can draw the blood there, and we have a pickup service. So that also benefits the patients from having to go out into other facility. We have medical counseling and health education. We really try to work with the patients for their smoking cessation needs as needed, and medication management. We are involved in case management, so we do make referrals to other agencies in the area. We don't have a lot of we don't have the specialty services, so if they need a specialty service such as GYN service, or if they need to see the kidney specialist, or they need to see a cardiologist, we make those referrals to other agencies in the neighborhood or over to USC, county, or one of the other hospitals that can further assist them with referral needs. Again, the night nurse clinic is right now 2 evenings a week for the families. Helps to decrease the number of unnecessary ER and urgent care visits and associated with transportation issues and calls to 911, because that was an issue where moms would just call 911 if their infant had a fever. And if they are told to go to urgent care by staff, the transportation needs were a separate issue. You know, trying to get on the bus with a sick infant is not optimal at all. And then we supply those over-the-counter or prescription medications that can be used, and then they can follow up the next day. So both of the nights that we have night clinic, the next day, of course, they can come in and see someone for follow-up care, so we can keep a close eye on those children especially. We provide TB testing. We hold a clinic every Tuesday down in the day room, the men's day room. The mission requires that all residents have a TB test within the first 8 days of their admission to the mission. So we provide those tests. We do a clinic day just so that we can get a large number of clients or potential clients or residents for the mission, and then they can come back on Thursdays to have those read. We do offer the TB testing any day that someone comes, except on a Thursday, because we're not there on the weekends. So we are open to having PPTs done, but just we do a clinic on Tuesdays. If their test is positive, then they will be sent for a chest x-ray across the street, and we actually escort. We have a volunteer from the mission who will take the person across the street to the county clinic, so that we will make sure that they are followed up with. So we fill out the paperwork, and then they are escorted across to the actual counter so that it's made sure that they get the chest x-ray, and then we are provided with the results so that we know what their follow-up is going to be. The SHRAT visit, if you can see, they call them SHRAT visits. When a family is admitted to the mission, they have a case management SHRAT visit, which stands for Skid Row Assessment Team Assessment. They have that upstairs with case managers, and then then they also have to have a medical SHRAT visit. So we see families when they're admitted to when they come into the mission. That can be a family of 2, it can be a family of 8, it can be moms with the children, dads with the children, or an intact family with the children. So we provide, it's really a wellness exam. So all the children get an exam. We make sure that their immunizations are up to date. We're hooked in with the Vaccines for Children program. So we're able to offer the free vaccines to all children, whether they have insurance coverage or not. And then the mothers or dads or both are also assessed, and we make sure if they have any chronic illnesses such as diabetes or heart disease, that they are also assessed. If they need refills on their medications, if they need referrals out to a specialist, we make sure that happens. If they have a primary care doctor, we make sure that that's followed up with. If they would like us to follow them while they're at the mission, because they can be at the mission long term. You know, families are supposed to be 45 days, but the individual programs for men and women, they can be up there for a year, 2 years. So we are considered their medical home. We can get their records so that we can do a comprehensive view of their medications. So besides our services in the mission, we also collaborate and refer to USC has a dental clinic. We actually share a waiting room. We do perform pre-dental screenings for all the dental patients. So that allows us to also help those clients when they need additional help with their medical needs that may have not have been addressed for quite a while. Mount St. Mary's University comes on Wednesday afternoons, and they provide physical therapy. We refer to the program. They are allowed initially 12 physical therapy visits for free. That can be renewed if needed, but it's been a very valuable service, and they'll see children as well as the adult patients. Pepperdine University has a mental health clinic which provides therapy, individual therapy, and there is some group work that's being done. I am personally a family practice and psych, and so I've started working with Pepperdine much more closely to provide medication management in conjunction with their counseling services, and we're also collaborating on a health education support group for clients with chronic illnesses, so that they understand that what the medical side of their illness is, and then what the psychological impact would be. So we have those three services that we collaborate with in-house, which I think is a very valuable service to our residents, and then we can also refer outside of the clinic also. So when we think about what we offer, I think we offer great services to the clients within the Rescue Union mission, the mission, and also to the community there on Skid Row. But what are some of the barriers that we've seen? We're a very new staff there at the mission, so we're coming in with fresh eyes to see what we think are some of the issues. One of the issues we see is women's health services. We provide basic PAP, women's health wellness service, but we don't have that OBGYN backup service that would be very important if we had different funding sources to pay for those type of services from a specialist, and to also offer the variety of birth control methods that would be available to the clients. There are a couple of other services in the vicinity, but one of the drawbacks as a barrier to the women is that they can't bring their children. And when you have 4 children and 3 of them are under 5, only one is in school during the day, how do you get that service done when they won't allow you to bring your other children? And so we're seeing women not taking care of those important women's health needs and wellness needs because of that. So that would be something that we feel that if we were able to get the support, we'd be able to offer that service within the clinic, because we could make the arrangements for those children to be cared for while they're being seen. There are volunteer services within. They swap babysitting services within the mission. If I have to send a patient to urgent care and they have children, I can work with the case managers within the mission to get the children cared for while the mom or the dad have to go over to have urgent care services. So we can make that happen within, but we need the support to have those services in-house for us. The other thing is, while I've started seeing the mental health patients, the medications are the bigger issue. I can do the evaluations, Pepperdine can do the counseling, I can prescribe the meds, but psychiatric meds are very expensive medications to offer patients. Even with insurance, it's very limited on what is paid for, and to have those in stock is very, very expensive. So that's another barrier for mental health services, is the cost of the medications involved. Another would be transportation for referrals. We have bus tokens to give clients, and certainly in the daytime it works. The mission has a taxi voucher service, but those funds run short very quickly within the month. At the beginning of the month, it's a good thing. By the end of the month, it's a hit and miss whether they'll be able to do it. Many times I can get it because I want to send a child to ER, urgent care, and they seem to, we all find a way to make that happen for them. But, funding for a better transportation service, or funding for the transportation that is already provided, would be a good service to have. And the clients don't want to always ride the bus with a sick child, or if they're sick themselves. And sometimes we don't feel it's appropriate for them to take the bus services, because we don't want something to happen to them while they're on the bus. We don't want something to happen to a sick child while they're on the bus trying to get a half an hour, 45 minutes away. So that's something that we'd really like, that would be helpful to the clients within the Mission and on Skid Row. The other thing that would be helpful is to have comprehensive clinic services throughout the Skid Row area. I mean, we've been there for 33 years, offering what I feel is a very good service, but we are the only comprehensive for women and children family services that is on Skid Row. And if we could duplicate that service in some of the other missions, I think it would be very beneficial to those residents also, even if it was just having an in-house clinic in their service that's in their clinic, because that is the unique part for us, that we're inside the mission itself. So inside of a rescue mission or Guadalupe, that would be important, and we know how to do that type of service. So I think it would be something that if we, again, had additional funding, would be a great thing to see, that each of the missions could have a clinic service within their facility and not have to go to the county facility that's in the area. Not to say it's not there, but it's not part of their mission. And, you get to know your clients, and you get to know the families, and they get to know you and to trust you. And a lot of that is very important with mental health services, that the clients trust you to help them with their mental health care. So those are just some of the barriers that we've seen, and this is our clinic that we are really proud of. So any questions?
First of all, thank you so much for coming, and this is such a wonderful service that you're providing on Skid Row. I know we have a few questions. We'll start with Commissioner Hisarich, and then I have a few questions.
Thanks. Just a couple of questions. One, are you reimbursed from any source for these services? I mean, if they're eligible for something, can you?
At this time, no.
No, so it's all just on your back, so to speak.
Right. We do get some funding from Northeast Valley. That's a FQHC. They fund quite a few of the services in the Skid Row area, so we get some funding, but certainly not anywhere near enough to do what we do. So UCLA does.
Pays for it, basically.
The School of Nursing pays for it.
Yeah, the school.
So that's part of our budget, and it's budgeted
Right.
in.
And that's one of the issues that, we're in the long run trying to work on, is because we are considered, for many of the clients, their medical home. Yeah. But if, as we know how Medi-Cal works, they've been assigned somewhere. That place is getting that capitated amount. We get nothing to see them. So, we do look and see who has insurance. So we know they have insurance, but we aren't able to. No, it helps them for some of the medications. It'll help
referral.
For some of the other services, but for our services, no.
Now, you mentioned the 911. They know I'm fixated on all this emergency ambulance service, but have you coordinated with the firefighters and the paramedics? They can't bring them to you by state law. They have to take them to an emergency room.
Right.
But if they go out to somebody that's a chronic emphysema patient or a kid with a recurrent situation, do they have information and that they could say, gee, here, rather than call us, could you go here? Here's some information about how to do that.
Our information's out there. Like I said, the clinic's been there for 33 years, so they know we're there. And we will see people. They don't have to be in the mission. That is one thing we don't.
It might be useful to really, there's about 3 or 4 fire stations that serve that immediate area, to put something in the hands of those people on the ambulances and the engines that would remind them, because they know who the clients are.
They're posted. Flyers are posted all over the mission, and they are at our post 11, which is the guard station to get in. It's posted there, and they come up to us all the time, so they know that we're there. And sometimes we call and we don't really need them to take the kids, just maybe to make sure, because especially with the children, that's where my heart is, and I always want to make sure that we're not there at night to make sure that we're still overseeing what's going on with them. That's.
Oh, go ahead.
Go ahead.
Most of the services are rendered by nurse practitioners?
Yes. Okay. We do have a medical director, physician, who is on staff, and we have backup physicians who are are on call that are ER docs. But, you know, we still, like I said earlier, it would be nice to have those additional services, but we do have to pay all of these physicians to be on call and to be on staff. And so, but, you know, funding only permits us to have so many of them on call. So right now we look at, you know, they're mostly family practice docs, of course. We have those couple of ER docs, but, you know, those specialties would be nice to have, you know, available to us also.
Thank you.
I have a question.
Okay, Commissioner Cato. Cato.
Hi, yes. You've been there a while. Is there any data being taken showing how it's reducing the number of, let's say, people from Skid Row having to be taken to ER by being serviced through your in-house?
There probably is some data. I mean, I've only been there since May, so
okay.
we're all a newer staff, but I'm sure there's some stats that have been collected at some point. I could get that information for you to show you exactly how many clients, because they know at night there's probably about 1,500 people in the mission because they put the cots out. So, you know, how many calls they've had at first. I think an interesting way to look at it would be the weekends versus the weekdays, because the weekdays we're there, our hours are extended enough that we can see a lot of people before the evening, and then, but on the weekends there's no coverage, so to see what the difference is and what the calls that they have to make. And then of course a lot of that's seasonal, because we're getting ready to have our flu season. What I think is a big thing that we're going to work on as a new staff, and again, services that could be expanded, are more educational services. I mean, you have a mom that's been on the streets since she was 15. She doesn't really know how to take care of that child, you know? So when her child gets sick, she panics. And what do you do when they panic? You call 911. You don't call, you know, you don't know. So we're making ourselves very visible at the mission so that they know to come to us. So now when I'm riding the elevator, moms are like, I need to bring the baby. Or, you know, we walk through at lunch. Part of that night clinic is to go down to the cafeteria, and walk around and just walk through the cafeteria while they're eating to see if anybody needs anything. When we get dropped off in the morning, because I ride the train in to town, you know, how's the baby? How's everything going? Just bring them by, let us look. You know, we'll just peek in the strollers. And you really get to know the kids, and you get to know the moms. And a lot of it's a trust-building relationship to get them to come in to see you. You can be open 24 hours, but if they don't trust you with their children.
So do you have the resources to be conducting like health and wellness type of classes for the people there so that they can be more? That
would be we don't at this point. We're just busy seeing patients. We have 2 LVNs and 1 full-time NP, a part-time myself, but I'm doing administration, and then I'm doing the psych too, which takes up a lot of time now. But that's another position within our structure that we would like to expand on. But again, that's a funding issue where we could get people that would do that.
So at the School of Nursing, we have we have 4 nurse practitioner programs, and one of them, the largest, is the family nurse practitioner, which currently takes in 40 students a year. So we graduate 40 family nurse practitioners. We are very much in a position to do more down there if we had more resources, and we want to do more. So there was, as Dr. Freeman said, in May there was a restructuring, and part of it was we knew we had to do more, and we need to look at how we delivered services. So we did a restructuring and a reorganization, and we actually, some of the care providers, instead of medical assistants, we went to LVNs. And but one of the things that, you know, kind of handicaps the nurse practitioners in the state of California is the fact that they do not have full authority to be function as nurse practitioners as they were trained, educated, and certified, as compared to there's 12 hospitals 12 states in the country that do not have full NP authority, and we are one of them. And it's kind of sad given the size of our state, the healthcare needs of not only Los Angeles, but just think of the rural areas. So the California Association of Nurse Practitioners is working very hard to change some of that, but it is an uphill battle, unfortunately.
Okay, thank you very much.
Commissioner Mendel.
So I think the point that you've made is that it's a resource issue. So if you had more resources, you
Yes.
could expand your services,
We would like to.
longer hours, or even on the weekends, which you currently can't do. You could hire more nurse practitioners or have more students that rotate through.
Right.
It'd be interesting to justify to the city. It costs about it's charged about $1,860, I think, per paramedic run.
Right.
So if you could demonstrate in a short period of time, say a 3-month window, if you did a study or you had a nursing public health person do a study, if we could save, say, theoretically, 400 runs, then even if the paramedics would bill Medi-Cal or some other entity a little bit of money, the truth of the matter is that would give you about $600,000 extra in funding if you could just document that we're actually saving money and be more efficient and not tying up the emergency rooms as well. Right. And it would also allow the paramedics to be available for higher level emergencies, which would also put less pressure on the whole system. So as little as 400 runs. So all you have to do is really show scientifically. Potentially we could articulate to either the fire department and or other members of the budgetary process of the city council that we'd actually be saving money and saving resources for the city just by giving you the money to provide the services that you're providing.
Yeah. Just to go back to the other thing about our family nurse practitioner program, the subspecialty is actually underserved vulnerable population. So that is which is what the residents of the Skid Row are, and the homeless population. So the students love it. They love taking care of those patients. It's very much a challenge, but they really enjoy it. So that's kind of nice.
And I can get you that information. There was some information and it was some data that was already collected that showed what the night clinic, just as it is right now, how much that saved in cost savings by having that clinic open and not having the families or moms call 911 or even go to the urgent care at night, because that's what they do. They leave, go to urgent care, they leave to go to ER, and just the savings on an ER urgent care visit was significant, and I can get you those numbers, besides even the paramedic cost. Just that cost savings alone was great. And the fact that we can provide the medications, the basic medications, of course, if they need to go to ER, they're going to go, but the savings just from being able to give them medications there and run laboratory tests there, which would be significantly cheaper than getting that done in an ER setting.
This is Commissioner Shannon. Thank you. So I have a few questions. One, if we could just go back to the TB test requirement. Mm-hmm. Do you provide those tests for free?
Yes.
Or okay, great.
Yes.
And then I'm wondering if you can talk about the dearth of specialists in the area and how difficult it is for people to get that type of treatment from specialists or transportation.
Well, like I said, for women's health, there is a downtown women's center, but you can't bring the children. So the moms go and they say, well, I had to bring the toddlers, and they told me I can't be seen with the toddlers. So that's a big hindrance right there. The Weingart Center is across the street as the county clinic. The clients, we do send them there for specialty care because we have to. That's where all the specialty care is. But of course, they have to wait for appointments, just like any other clinic setting anywhere. There's a wait time to get in to be seen. Some of the specialties need to be handled over down at USC County, and again, there's a big wait time. There might be a month, 2 months to get in to see a specialist. There's downtown mental health, which also takes time to get in, so it may be a month or so. What I'm saying with mental health, someone comes into the mission, they have obvious mental health issues. For them to get services or to get their Medi-Cal in place and to get in may take a couple of months. Well, what happens with someone with their mental health issues that aren't being addressed? In that setting, which is very crowded and chaotic at times, they start to decompensate. They decompensate to the place where they may have to be hospitalized involuntarily because they have not been able to handle the living situation that they're in. So we hate to see that happens. I'm trying to do more assessments in conjunction with Pepperdine, if I need them to do a different type of assessment. But I'm trying to keep the patients out of that situation where they have a 5150 called on them, because and you can see them decompensating. They come in 2 or 3 weeks, you can see the change in their demeanor. So being able to have the medications, the funding for the medications that I would need to really get them under control quickly would be extremely helpful. In the private setting, I'm also at a private practice, I've got a closet full of samples. It's a different type of setting. And so I can medicate patients quickly, give them plenty of samples to take home, and I don't have to worry. But in this setting, that's not the case, where I have the availability for what a private practice has at their fingertips. So I personally know the difference, and why it puts me at a different disadvantage to see my clients here at the Mission.
I wonder if you can speak to any kind of outreach that's done in the community for people who are not actually at Union Rescue Mission as a resident of the Mission. In other words, people who are maybe sleeping outside the Mission, along 6th and San Pedro. I know there are a lot of people that are there who are fairly ill, because we were out there a week ago doing outreach at night. And I'm just wondering, do you do outreach into the community for people who are not residents? And is that something that you could expand in terms of?
That was something we will expand on, I think, just because we're so new in getting all of the staffing. The medical director just came on about a month and a half ago. So we're still trying to get all of our staffing in place. We have done a couple of fairs at some of the other missions, the Midnight Mission. We did go and have a table and did health screenings there for them to get the word out, and took flyers with us to those events. So we've been trying to, become more visible. And I think with the winter time, we will be able to do that. They used to run a foot clinic, the old staff, and we intend to get that up and going again. They do that on the patio area. In light of some of, to be realistic, in light of some of the activities that have been going on just on our block with the drug issues, the spice was right on our street. And so that has pulled in some of the outreach on the street, just because of the risk of health of the employees and staff, and the firemen and the policemen also, because they were also getting sick from the fumes. So we haven't been out and on the street as much as we have the potential to do, in the future with the Mission.
So people, though, can come to your clinic even if they're not residents?
They don't have to reside at the Union Rescue Mission. So we do get clients from the street that know that we're there. They do send them down from the Midnight Mission, from Guadalupe, from some of the other programs. They do come over to the Mission. So they are referred over from the other mission sites. It's just that because Weingart is the, I think what's interesting, a lot of clients do have the ability to get health care coverage. Now, whether they're using it or not, that's a whole different story. And so since they have coverage, they can pick and choose how they want to use it, and they will go to other places. So, but we did a recent survey that looked at whether people considered us their medical home. If they came to us, and they did consider us. We pulled 600 charts, and the majority of those clients did consider us their medical home. And these were people that came, they had to come more than once or twice to the clinic. So they do use our services, and since we don't charge and we don't hassle them about payment, they feel comfortable in coming and using our services, whether they have insurance or not, because that's not an issue for us. At this point, we would like to, get into the payer mix at some point if we can, because that would be helpful to help expand our services. So, but at this point in time, the funding issues are important for us to be able to receive funding. Otherwise, until that can be something that we can get into.
Does the City of Los Angeles currently fund part of your program at all?
No.
Nothing.
It's it's the School of Nursing, and then a small so the funding that we get from Northeast Valley, a small amount from Northeast Valley, but that's it. And we don't ask the clients for anything at all.
Okay, I have just one more question. On transportation, one of the recommendations that came from one of the doctors who spoke here was to have a shuttle. And would you find that helpful to have a shuttle that was going maybe to county hospitals? Actually, I have another question after this.
Yes. Yes. That would definitely
There was
be
an ongoing shuttle going from downtown or
right,
various
and one
areas.
that would pick up, I like to put the caveat, one that would pick up in front of our mission, because there is an access van that is county run, but it doesn't pick up in front of our mission, so they'd have to go, I'd have to say, take your sick baby outside, walk down the street, walk down a block, wait on the corner for the next time that they show up. That's not reasonable.
Yeah. Are there any other transportation recommendations that you could make? I mean, other than having more resources, more vouchers, that kind of thing. Other than that, is there anything else you could think of?
From a transportation?
For transportation, yeah.
I can't think. I think just having a shuttle, if they had one that ran to county, because that would be the longest distance, I think that would be helpful. One that went to the urgent care, or that made the rounds from the emergency to the urgent care. Because it doesn't take that long to get there, but if it has to stop at every other clinic, at every other place, that makes it hard. It's like having your seniors riding the access that they have, and I hear that as a complaint. It takes so long, you have to wait too long, because we're only asking for emergency services. Then if they had a routine one that would take people for their routine visits, that they could have another service that would just run. You would know you'd have to be on the van for a little while, but to have a bus that would be able to accommodate moms with strollers, accommodate moms with with babies and infant carriers. That's really important to make sure it accommodates people in wheelchairs. And it's not, if it only takes one or two people, because then once it gets a wheelchair, it's full. That's not accommodating that mom with the 2 or 3 kids in the stroller or the infant carrier, so that she can get that sick baby in to be seen.
And one last question. Are you connected with the county's Housing for Health program?
No.
No. Okay.
Do you have an idea of what percentage of your patients actually do have a Medi-Cal that is capitated elsewhere?
I think we figured probably about 70% have, say, LA Care or HealthNet.
It'd be interesting to see if there's the same collection of providers that are getting their monthly payment from Medi-Cal, and you're seeing the services. It'd be interesting if you could potentially, or we could help you reach out to those providers to give you not total funding, but a small amount of just quarterly or annual funding to support your services, because they're actually benefiting from your existence. And if UCLA School of Nursing decided to close the clinic, then the population will lose out, people on Skid Row would lose out, and those institutions that are making profit currently from your hard work would have more of a burden.
Right, because they'd have to actually see the clients.
Exactly.
Right.
No, and we know I think they even know that that's the case. I think with the different entities out there, they know that that's the case if they're going to a free clinic. But we have to get into that some kind of relationship with the insurance companies to have them really want to change their system. That capitated account system is a
That's mandated by the ACA.
Right.
So
they have to do it, but get us. We have to get in the mix so that we can be the medical home for these patients. That's a real important, and that's something we're starting to work on to see if we can get on as an insurer entity. But it's hard. That's hard. That's a hard place to break into.
Yeah, you don't want to do that.
Yeah.
So if 70% are utilizing Medi-Cal, would you say the other 30% are uninsured?
maybe Medicare, small percentage with Medicare, small percentage with straight Medi-Cal, which is different, of course, from your capitated.
Right.
So we do have some that have straight, a few with Medi-Medi, because if they're already established mental health patients especially, they're going to have Medi-Medi. Or if they're in stage renal or in stage COPD, they're going to have Medi-Medi. So, we see a small percentage of those patients too. And that's, actually over the last few years, that's what's helped us to be able to maintain our dispensary, because everybody doesn't need to have free medication anymore. We need, I think the mental health component, which is something we are just getting into since I've been there, is a big one, and that's an expensive one, because the meds are just not, because of the supply and demand, those meds have never dropped in price. A med was started out in 1980, you would think by now would be pretty cheap, and it's not. Still over $100, $150 a month. So,
could I
Any other
just
questions?
follow up on that? If
Commissioner
veterans, you have a downtown, there's a veterans clinic. Do you all refer veterans over there, or get any money from the VA?
we don't get any money from the VA.
Do you are aware that they're not too far away? There is a fairly sizable VA clinic that
Right.
maybe you could get some over there as well.
And that's if the patient has disclosed that they're a vet. We
Yeah,
do,
no,
we do eligibility up front, and I wouldn't say we have a large,
No, not a lot of that.
not a large veteran
Well,
pop.
that's saying they are, so.
Yeah, they aren't in the mission. They aren't saying, not to say they're not on Skid Row, but when they come into the program, that might speak to the fact that they already know about that service, so that they're already being serviced by the veterans. They do, but they can come and use us if they've just got a cold or whatever. And some people are afraid to disclose too much, because they think if they disclose, then it will hurt their other services.
Yeah.
And they know that we're free and we're not going to turn them away. So they don't have to tell us everything. We're not going to interrogate them about it. So.
Thank you.
Any other questions?
Any other questions?
Well, thank you so much. for
Okay.
having
Thank you so much.
Thank you for coming. Okay, we will move on to public comment. Armando Herman.
Going to have the puppet Dr. B speak to you guys.
Well, you heard it. How fucking stupid all these ideas are, because you still don't have enough money to work these problems out, you jackasses. So as long as there's poverty in Los Angeles and you poverty pimps work with Herb Wesson, that fucking smoker with bad breath, you'll understand why the world's fucked up from a guy that can't pay his bills on time and goes into mortgage fraud and voter fraud. But you don't care. If you really cared, you would actually walk once a week under all the conditions of the homeless people and people with mental disabilities who live in the streets, you jackasses. Howard, you brought up the first question. How much is true? How much fucking bullshit, Howard, do we have to live with? Seeing people on a constant basis living in the street homeless without medical expenses to pay for? It's fucked up, Howard. You gotta learn something from this. As long as I have 42 USC 1983 to speak my mind and say, fuck you, Herb Wesson Jr., for all the poverty you created in Los Angeles, you pinche baboso, look what you've done to our city. Not only have you created an unhealthy, safe environment, you brought these poor ladies here to expose more poverty by you pimps. So either you work on becoming a solution or become sangrones, puto sangrones that go around pointing pins at people. I'm talking to you. No, fuck you. Leave Herman alone. Don't point your hands at him, because if you don't want him to talk about you, bitch, then you better watch what you do around Herman. Because after all, I'm a cute little bear under this hood, and you should know better than that.
Okay, now we'll move on to item 2, which is discussion and action on content related to the Los Angeles City Health Commission annual report. So we have two, I believe, do you have? Okay. So we have 2 written documents that have been circulated, one from the Lifestyles Work Group and the other from the Homeless Work Group. We can start with the Lifestyles.
The Healthy Living Work Group circulated recommendations electronically earlier today. Commissioner Cotto, Commissioner Andres Taylor, and myself spent some time trying to devise a rationale for which recommendations fit within the jurisdiction of this commission, and we welcome your reactions, suggestions, and commentary regarding how to make this as useful as possible. I think the most important flag to raise regarding the subject matter that was included in the Healthy Living Group recommendations is virtually everyone we talked to and everyone we heard from has made a recommendation that was captured in last year's Plan for Healthy Los Angeles, which the City Council and the Mayor adopted as a broad framework for health strategies to improve the health status of residents in Los Angeles. And so our primary recommendation, as you'll see, number 1, is to actually push the city's leadership to act on those previous recommendations, since they appear to be still active and in many ways endorsed by many of those who came and spoke to us. So it's our judgment at this juncture that it would be best interest of the residents that some of that move forward, and perhaps most importantly that it get tracked, which there are not the resources devoted to do today. The second and third categories of recommendations involve both acting on some of the specific suggestions that folks brought forward to us, which are enumerated there in terms of healthy eating opportunities, disparities in parks, et cetera. And then the third area of recommendations is to try and strengthen the coordination between the city and county health departments, of which there are 3 that we are ostensibly charged with oversight of in the particular language of the ordinance. And our suggestion on that is to identifying a few specific ways to improve coordination, beginning with getting together this commission with the commission that is in charge of citizens that are assigned to provide oversight to the county health departments, and determine whether there are some areas of overlap or mutual research that could be better conducted to determine how city residents could best benefit from the range of policies, programs, services that are underway in varying ways across the 3 county health departments. So that's just the briefest overview of the document, which Dr. Mendel, if you could just hold up so folks could see, which I realize folks are paging around trying to track what on earth we're referring to.
Number 2.
And I pause here. I ask Commissioner Cotto to make some additional remarks on behalf of the Healthy Living Work Group, if you so choose, and or welcome the input of those gathered around this table, or these tables.
I visited Councilman Rue's office last week, who is the chair for the Mental Health and Education Committee for the council. And as it's written here, it's a matter of who will take the responsibility to begin the implementation of the Plan for a Healthy LA so that data can be garnered to track whether this is really helping to promote a healthier Los Angeles. And, I've been on this commission for less than 6 months trying to understand how the wheels work with our responsibilities through the ordinance that was created, working together with the city, and I haven't been able to get over to our county counterparts. But hopefully, while through this, there's, as Commissioner Sharp had pointed out, that our goal is working to see how we can try to reduce the chronic ailments that are here, and we've got to be able to. And it starts with the implementation of the plans, and it seems like there is still like a barrier for that part to get going, and so hopefully in the second annual report we'll have numbers that could be showing how there has been improvement. But unfortunately, I don't think in this first year we're going to have data. We'll have recommendations, but not data.
Okay, great. Any questions?
Commissioner Hawkins just had a comment. Thank you so much for this. It's very comprehensive, and I like the how it's broken down into each subset and putting it back on the issues that we do need to report back in enforcement. So I think this is a great starting point. So thank you for pulling this together.
Thank you.
Yeah, I feel the same way, but I would add that gathering data is certainly critical just to know if one's moving things along. But in order for there to be engagement on the city side, I presume it's because there would be, beyond data, there would be particular outcomes which would capture the imagination of parts of the community, either because of what they've accomplished or because of a revenue opportunity. We heard even of one today, which was like the engaged, like the embedded clinical services we heard at the mission, and that could go, as Howard was saying, with something which this innovation in care delivery, which is outside of the county purview, so it's complementary to that. It also could be resourced in part by sparing city resources. So it seems to me that if we wanted to implement beyond simply gathering data, to get to certain of our councilmen to find out if any of these look like they're like the 2 or 3 where there might be something where we'd be able to have something evocative to show at the end of the year into one category or the other.
Thank you, Dr. Brown. I wanted to clarify there's 3 types of data that are needed to know whether the world's moving in the right direction. One would be data regarding specific policies acted on by the City Council and the Mayor. And there's some indication that among the 86 recommendations, many have been acted on. That is not collected in a central place. Many of them I'm aware of from the newspaper, and so I embedded those in here. The second set of data are data about activities happening in the community that may be led by a medical institution, community-based organization, a nursing clinic. A number of the recommendations are community-facing, and that needs to be captured. It's very expensive to collect in a standard format because every community organization is going to report enormous outcomes to their funders, and it's difficult to accurately distill that into a series of comparable data points. The third data set, about which I'm most optimistic, is the actual measures of the health status of residents. As we heard earlier today regarding the rates of smoking among Los Angeles residents, the source is the LA County Health Survey. That is available. That has been updated. It would take some analytic work to extract the most recent data points for residents of the city of LA. That was last done in 2013 for something called the City Health Atlas, which was published using the data points at that point that were contemporary. So there are 3 different types of data that are useful to track how things are going. Each of them are at different places, and we are hopeful that in the future there would be the resources to update all 3 of those to present a more comprehensive snapshot.
It's interesting that if you look at where the funding really comes from, the overwhelming funding comes from either the federal government or the state, and just passing through one clinic or one organization. And yet the congressional districts don't collect data. And LA County collects data, as we've learned, in the SPA system, which doesn't overlap with the city council. So we have our representatives at the federal, state, city, all not getting the data they need in their own localities, and yet the county is collecting data that doesn't overlap. And so perhaps something for us to consider or having a discussion with the county is perhaps now with new computerization that they actually analyze by both congressional district as well as by state assembly and state senate districts, because it'd be interesting if we could have input from the representatives that have been elected to represent the people who are currently not having access to health care.
Any other questions? Okay, what, Commissioner Sharp, what is the timeline in terms of having sort of this section of the report written out?
Well, barring further edits from the esteemed group here and or any that are not with us today that wish to provide edits, I believe it is available to move forward.
Great. Thank you. Okay, and then you have a second written report from the Homeless Working Group. There's been actually extensive research on various sections of this report. So we are making specific recommendations. This is the Homeless Working Group. We're right here in two. No, this is part of it. This is a report. This is part of the City Health Commission annual report. So we are making several recommendations of the city, which will, in some cases, supplement what the county is doing, but doesn't have enough resources. And because there's a substantial cost savings of moving people, particularly who are homeless, into housing as part of a healthcare strategy, we are recommending that the city be part of these programs. So the first is Housing for Health, which is a C3 program, which means that it's a county, city, and community program. Currently, Housing for Health only gets about $100,000 to $200,000 from the city, and that's coming from discretionary funds from city council members. And so you could see because there's a substantial cost savings for moving people into housing, and Housing for Health is one of those programs that's actually working really well, and that's run by the county and a government agency. We're trying to see if we can recommend a partnership between the city and the county, since a lot of people that are getting moved into housing actually live on Skid Row. So that is one of our recommendations. We also are making a recommendation to support the expansion of the county sobering centers. So if particularly on Skid Row, you can see that a lot of people, particularly are inebriated. There are several calls that are made to the LA Fire Department, and they are just constantly coming out. And so in a sobering center situation, there would be outreach. People could move into a sobering center, become sober while they're there, get some sleep, and then at that point, the county health department would do an assessment and try to move folks into services if they were willing to go into them. So it's a substantial cost savings as well, which is great. But it's something that we had talked about in terms of our homeless working group, in terms of recommending to the city to get involved in that program and try to provide resources. On veterans, one of the things that we were finding out is that there are a lot of veterans who are not getting connected to medical services, even though they're available. So providing education, a way to expedite service connections so that there aren't a large waiting time for them to access medical health services if they're homeless veterans, we found was really important in terms of making recommendations. Another recommendation that we're making is to support a shuttle system to county hospitals and clinics. That has two benefits to it. One is the benefit of providing, obviously, medical health services for people who are homeless. The second benefit is that it allows people to get connected to the Housing for Health system. The eligibility for that is that you have to visit a county hospital or clinic twice in 1 year and have an underlying medical condition. A lot of times, though, people actually can't get there. There are also other issues in terms of having their things on the street and they won't leave them, which is an issue of more of storage. But having transportation actually to a lot of these clinics and hospitals can actually help people who are homeless move into housing. So we want to make that recommendation in order to make it easier for them to get there. This is a huge problem in Venice. Most of people who in the homeless population in Venice are going to the Venice Free Clinic, and that does not provide them eligibility for Housing for Health or for any particular housing program. So sort of everyone working together to move people into housing obviously is a good thing. We looked at a lot of diseases and sort of the health impacts of street living. There's a lot of data actually on Skid Row, there's staph, strep, a lot of underlying problems, blood pressure, diabetes, issues that aren't being addressed. There's also a lot of communicable diseases. There are a lot of drug, not just users, but dealers, like you heard about spice. And I guess the latest information on that was that the spice was being, I guess, laced with Raid and something else. And I've been doing a lot of outreach on Skid Row through my organization, and I've been hearing this just from people who are on the street, that they felt like, there was this move to basically try to make them sick or potentially kill them on the street. And that's also coming in from some of the service providers. The Union Rescue Mission is also sort of saying that as well. As you heard from the woman who just spoke, that a lot of the service workers there were getting sick just from the smoke that was coming from the spice. Another thing that we were looking at is the lack of restrooms. So there are only 5 on Skid Row, and we're trying to get a number from Mike Bonin's office in terms of the lack of restrooms in Venice. So people obviously are relieving themselves on the street, which doesn't create a great health outcomes for people who are living there. There's also a substantial rat problem. I was there a week ago, and there was a man with a tent who had several holes in it. And literally, while we're talking to him and he's telling us that rats are coming into his tent, there was a rat's nest in the tree where next to his tent, and the rat just ran down and ran right into his tent. So that's another issue that I think creates potential health problems. And then we looked at some mental health issues. And then we had heard from Homeless Healthcare about the use of Narcan. So one of the things that we're recommending as well is to expand the availability of Narcan to first responders, nonprofit agencies who are servicing that community, particularly at night. There are not a lot of services there at night. And that would be in areas, not just Skid Row, but wherever there are large homeless populations. Questions?
Something to consider if we're going to suggest a shuttle is run the cost of reaching out to either Uber, Lyft, or some other new organization that potentially would give a discounted rate or look for the PR so that they could theoretically help the community of Los Angeles and help homeless people and have somebody else pay for it or have it given charitable Uber rides to homeless people for the PR purposes.
Great idea. Any other questions?
I have a couple quick ones, and I'm happy if it seems too long to join the small groups call briefly to talk about them. One is this sort of geographic applicability. In other words, with the homeless population having been documented in this year's most recent count as having spiked in so many corners of the city, which I think is of significant interest to those that appointed us, particularly throughout the Valley and other communities experiencing it, leading to the political support for Measure HHH, which will be on the ballot and voted on before we next get together. Is this basket of recommendations applicable, including, for example, things like a shuttle connection? Is that work as well? All this work as well throughout the entire city, or is most of it most effectively implemented within the concentrated community central city?
So it does work throughout the city. The reason that I'm referencing Skid Row a lot is just because we have a lot of data, and it's just easier for people to sort of wrap their brain around it. But there are county clinics, obviously, all over the city, and so running shuttles would not just mean from Skid Row to USC. It would also mean to county clinics that are in the Valley, particularly in Venice. There's a huge issue with this. So wherever, and that's why we sort of put in the report, wherever there are large populations or large homeless populations within the city, that's where we want to start connecting people, not just to healthcare services, but healthcare services that lead to housing, to help ultimately with better health outcomes in the future.
Great. Then my other question is also kind of general or global around the city's current homeless strategy that we heard from, I guess was the most recent meeting? Is that what Ms. Yolanda Chavez came from, the Chief Administrative Officer's office, to share with us? They have sort of a 200-page book of recommendations that the City Council Mayor's team labored with for months and months. How do these things fit within that world so that as we are explaining it, are these things that they may, or particularly on the housing bucket at the beginning, I don't think there's nearly enough in that about some of these health-specific issues. So I think these will definitely stand out as distinct from what they heard about earlier. As it relates to some of the housing strategies that are identified at the beginning of this, how is that discussed within the city's current strategy so that we're all familiar as we talk to people about it, how these things fit together, or don't?
So I've been involved a bit with the homeless strategy for the city of Los Angeles. And so these are definitely some of the things that council members have been talking about, but are not necessarily in that plan. And so they would supplement it. So the city's plan is primarily focused on increasing affordable housing, creating safe parking programs, so that people who are on the street have a place where they can go, a safe parking lot, which will probably pass sometime soon through the council. So a number of recommendations. These, though, are a way that the city can supplement what the county is doing in terms of programs that are actually working to move people into housing. So there's a little bit of a barrier, I would say, in terms of getting vouchers. There are homeless set-aside vouchers that specific organizations have, and if you are homeless, you need to get connected to those organizations, or you're probably not getting on a wait list. And if you do get on a wait list for Section 8, you're going to be waiting for 5 to 10 years. So that's why something like the Housing for Health program is so important, because it sort of circumvents to some extent that process. It's part of the process of getting vouchers, but also circumvents it through a flexible housing program. And a lot of council members are not even aware of this program. Some of them are, and we're trying to educate a lot of the other council members on this program because it's actually working and getting people connected to housing in a much quicker way than sort of the old way that we were doing it, which is just to send someone to the housing authority to get on a list that won't get them housing for quite some time. So it does supplement it to some extent. So it's not just making the same recommendations that the homeless and poverty committee is already making. It's going a little beyond that for their next group of recommendations. Any questions?
A question, Commissioner Hawkins. So what are the next steps as far as how far along is Northridge on the report? When are we looking at seeing a draft, or what are the next steps?
So our committee, and thank you for being on the committee, Commissioner Hawkins, and also Commissioner Ariola, and and Commissioner Vick, who isn't here tonight. So I think we're ready pretty much. So I think we should have a draft within the next week or two for our particular work group to look over and to make changes. And then we can put that out to the public and to the rest of the commission for comments. And I'd like to get maybe a week, give it at least a week for comments. And then we'll be able to present that entire section of the report for the next meeting.
And the following, the rest of the report?
So there's 2 other work groups, and that was one of the reasons why I asked Commissioner Sharp what the timeline was. So I'm fairly confident that will be done. And then there's the medical services work group that we're working on. But the goal is to have everything written by the 14th so that we can give that to the entire commission. And then we can vote on changes and then vote on the entire report given the amendments. And then we'll prepare the final document. And then there will be obviously printed reports that will go to all of the commissioners here, go to all of the council members, their offices, and some of the department heads. And then it'll be provided as well as a PDF document.
Thank you.
Any other questions? Okay, let's move on to public comment. Armando Herman.
I'll have the puppet address those who behave inappropriately like puppets.
So, you see, you're still running into the background of problems. You don't have a solution. Motherfuckers are still living in poverty in Los Angeles, but yet you want to add a measure or a bill called HHH. And what about 1618 and 1622? Mr. Sharp, aren't you familiar with Mark Leno from Sacramento's bullshit? A budget to help homeless people in Los Angeles or through the so-called embetterment of the Constitution of California? All of you are partaking in what I call crimes against humanity, because there's no fucking reason why any person with the type of money those assholes from Sacramento are throwing out to you to utilize it in the most efficient implementation way whatsoever. Go on, Herman, tell them the rest.
Well, I've been coming to these meetings, and I haven't seen one tremendous change other than the bullshit rhetoric that you can't help the public find housing. How much longer will people live in the goddamn street with rats? How much more time will that asshole Eric Garcetti, for the record, you hear me, Eric Garcetti, you dumb asshole, when will you actually implement the monies that go to people who need it? Actual people. Instead, you poverty pimp, like that Herb Wesson Jr. who can't pay his mortgage, stop fucking up a system that can actually work. There are actual people in Congress that care. But as far as I'm concerned, I will never put a vote on that stupid bitch Hillary Clinton. That's my opinion.
Okay, thank you. Moving on to item 3, update on research for council requests regarding mapping of wells and pipelines. This was left over from last time because we lost quorum. So I wanted to just give an update. I did mention that we had finally have an inventory of all the wells in the city and are beginning to look at which wells are leaking or have a history of leaks. So that was one of the things that the council wanted us to look at. So I was asked to attend the health committee, health and mental health committee for the city of Los Angeles. And one of the things that came out of that was an agreement that we would share our information, not so much in real time, but as we get it, because certain council members are moving forward on oil and gas extraction activities and how they're impacting their specific council districts. And so as we get the data that we're collecting, from Dogger or other agencies, we'll be giving that to the council members' offices. Rather than them waiting for a recommendation from us. And so, of course, we can still make recommendations, but they're interested in seeing the data as we get it because they're also working on things, and so are some of the city departments. So that's sort of what came out of that committee meeting, that was their request of us. And that's all that I have on this. Are there any questions?
I have a question not as much about the mapping, but about the sort of broader area that you were just talking about, which is sort of how we can be useful. And the city has, since we last convened, hired a petroleum administrator. I believe is the title. The gentleman who's worked in Long Beach City on oil and gas extraction for many years. And I'm just wondering, really sort of an open thought to you, who've thought more about it, and everyone else, whether it's useful or not useful to try and invite or engage that representative now of the city, sort of, I think it was selected through the mayor's office and will be located at the planning department or maybe building safety, to engage with this commission to more effectively refine what our role is to these other partners within the city and county structure on oil and gas. Is that helpful? Is that challenging, problematic? How does that relate to the process as best as you understand it from your involvement in this mapping?
So that's true. We do have a petroleum administrator for the city of Los Angeles now. He just he just started his position October 3rd, and I would like him to come and speak to us, and we can also meet with him or have him speak to the subcommittee on oil and gas, because we should have I think a fairly consistent relationship with him to know exactly what the city is doing and the data that they have, and to see if we can be helpful in terms of what they would like to do. And the city attorney's office is also very involved, obviously, in these activities. I spoke with the city attorney a couple of weeks ago about this and some of the work that they're doing. And one of the things that they're doing is recommending, and I guess it's going to be probably a mandate, that some of the oil companies in particular that are in these residential areas have monitoring systems that are very sophisticated, that will go off if there are any problems in terms of pollutants, excess pollutants coming out into the air, so that the residents actually know what's happening and the city can monitor that process. So I think that things are moving forward, at least from city attorney's office. Maybe not in exactly the way that we would like, but there is a lot being addressed, and people are at least recognizing that there are potential problems with oil extraction, and particularly in residential areas. Any questions? Okay. Armando Herman.
So if we're going green, why are we fracking, digging, pumping poisonous toxins from the earth, creating cavities within the earth? For every action this city and all those developers and all those special interest assholes that get involved in this type of environment, it impacts everyone's life, not just what their greedy, ambitious ideas are for. So maybe for those of us who are elderly and don't see the garden, that nice garden with all its flowers, there are no such gardens anymore, because we allow those pipes or pipelines to go through our cities, through our communities. The same way you did with Exide for years, the same way you did with up here at the Porter Ranch. What did Englander, the big-eared dwarf, do about it? Nothing. He only stepped in for media attention. The same repeated politician games. Look what I'm doing to better the community. Well, I got something better to say for that. Fuck those poverty pimps that really believe in their own idea and dreams, just like a greedy gangster. Let's do a comparison between a politician and a gangster. There is no difference. One is no better than the other than a gangster is better. Because a gangster will allow you to live and have things in your community. A politician, like Satan, will snake you and drive you to your grave over the issues that we all debate about on a daily basis, and you go home and you sit in your comfortable beds thinking about, am I making a change? Am I making Los Angeles better for everyone? Or am I only doing it for the establishment of what I believe in? Bullshit.
Okay, thank you. Moving on to item number 4. Okay, so this is also left over from last month's agenda. There was a substitute motion made by Commissioner Jaquez and Commissioner Vick, and there was language actually inserted into that motion that made it almost impossible for us to adhere to the requirement, which was to have any other entity strictly impacted invited to attend and testify at our meeting. So I think hold on. Okay, so apparently as the chair of the commission, I can basically make, it's not even a motion, but just sort of make the call to suspend this indefinitely. And then we can, I guess in the future, entertain another motion related to this. But unfortunately, the way it's written now, we just can't move forward with the specific motion. Okay. Thank you. You can do that if you want. I mean, I
You just did.
Great, thank you. Okay, so we have public comment cards for item number 4. Willie Rivera.
Excuse me.
Do you need to use the microphone? Please, for the recording. Thank you.
Willie Rivera, I'm the Director of Regulatory Affairs with the California Independent Petroleum Association, SIPA, who is the reason or the source for the very big packet you received at the beginning of your meeting, which I hope serves as good informative reading for you tonight and every night you need to get through all of it. I think this announcement clarifies a lot of things for me. Certainly, you'll see SIPA and WISPA and our members and folks affected by these types of changes engaged in this process moving forward. I think it is very important that your commission realize the real scientific evidence behind the safe practices you find in oil and gas production in LA, and the documents you've received earlier today can give you some more information about that. I think it's also really important to highlight, and it was touched on earlier, that you folks just hired a petroleum administrator. You hired that petroleum administrator because the LA City Council and the mayor wanted someone to work specifically on oil and gas issues in the city. And as it was shared earlier, he's only been on the job 2 weeks. I doubt he's even found the bathroom in the building yet. I think it would be very early and a real disservice to him and his office to put the cart before the horse, if you will, and begin taking action on any issues without the full engagement of your new petroleum administrator and seeking his input and counsel. And then I think the last thing is that there are certainly real impacts to these types of decisions, and wherever you fall on the supposed accusations you hear of often, the real impacts associated with shuttering in oil and gas in any part of California means there are real impacts to the people that work in those areas. There are real impacts to companies. So I'd encourage you to keep that in mind. You're certainly working on great work, and I would encourage you to continue moving forward on those items. Thank you.
Armando Herman.
Well, with any regard to the Ralph M. Brown Act, apparently there's a broken promise to follow that, because you're making decisions that impact the community, the stakeholders of Los Angeles. Yes, the gentleman, as he spoke, is speaking in regards to his company and for his company, but not in the interest of the public. We are the interest of the public. All you on this commission, whether you're a scumbag or not, or a douchebag or not, that's not my decision. You were allocated for that position and seat by a dumbass mayor who takes no action and responsibility to care for his actions. So I will say exactly as I mean it. Because until Eric Garcetti can actually do his goddamn job instead of running around campaigning and working with special interests and use his transparency to prove I'm wrong, then come here and debate whether I'm right or wrong, so that everyone here will know whether or not the items gathered on this item number 4 are factual or untrue, and that my arrogant statements of putting it straight out is whether or not, and I'll put it clearly, as John Walsh, HollywoodHighland.org would say, is the mayor gay or not? Is he in love with the DWP or not? That's for you to decide. That's his opinion. My opinion, I don't give a fuck. All I care about is what's good for me, will be good for the community, and as long as I have a share in that part of it, then we're in agreement. Other than that, it would be like the scenario of Jesus being on the Mount of Olives. He says, pay to Caesar what is Caesar. I say that because I'm in an environment of a church. So you decide who you're going to pay back what you promised and broke on these arrangements. Read the facts.
Okay, thank you. Moving on to item number 5. These are items for future discussion. Does anyone have any recommendations? I think at the next meeting, obviously, we're going to be focused primarily on the report, but if there are other things that people would like to add to the agenda, this would be a good time to let me know.
Hi, Commissioner Hawkins. I just had a couple of questions, just an update, because I believe that was a one-year term that ended in October, so I'm just trying to get a better scenario of this commission, how long it's supposed to be enacted, and in our role, as well as the report. Kind of just want to focus on that primarily.
I think it's our term started on the first meeting when we were sworn in, which was, I want to say, November 16th.
Okay.
So today would be the 12th meeting, right?
Well, we weren't, yeah, but it goes from, it's not, it's a one-year term. It's not how many meetings that you have.
So it's 12 months from the date of the swearing. Got it.
Yeah.
So then at next month.
So we're commissioners
until
November 16th. Are you sure it wasn't 20-something?
I think it's usually until the replacement is.
Or until the replacement is found.
So maybe a
Okay.
future agenda item
Yes,
that I'd like to consider is at least some remarks on this, or at least a brief summary from either clerk or CAO or someone, because there is some confusion about that. That would be good to know.
Okay, thank you.
But we're definitely until November 16th,
Okay, got
as far
it.
as I know. So you're still on duty.
Follow-up on that would be is what each individual council member wants of us, whether they want us to keep on serving as individuals or they want to replace us, and is there some way to just have the city clerk ask the chiefs of staffs of those 15 council members what they prefer?
I'll go ahead and check with them. I haven't heard anything, so I'll go ahead and check.
I think as well that, I mean, I'm guessing most of us have some type of relationship with the council member's office, which is why we were appointed. So I think you could also call the council member's office directly who appointed you and ask.
Yeah, it's just more efficient for the city clerk just to check once instead of us all making 15 phone calls that they might be wondering what we're calling about and tying up their schedules, just from efficiency, productivity point of view.
I agree.
Okay.
I'll go ahead and check on that then.
Okay, anything else related to the agenda, or would you guys prefer that it be mainly about the report?
Mainly about the report.
I think that's the best use of our time.
I think so too, okay. Okay, public comment, Armando Herman.
Really nice to have 2 minutes. 2 minutes to vent, 2 minutes to rant, 2 minutes to exercise your First Amendment when it comes to the quality of our life, whether it's through illness or whether it's through a non-disability, right? You would know. Just by looking at you, we could say you have a disability. But that's not the fact. It's not the truth. I think in the next hearing or the next motion to add to the items of agenda, we should talk about the county board's ideas of what's appropriate in addressing the concerns of your constituents. People, all of you on this commission are serving. Rather than just have one individual or have none. I'm the only public comment person tonight speaking on all the items. And I will do it as long as I can. As long as there's a Wayne Spindler. Let's take, for example, that issue. A person submits a public comment card. He draws some pictures on it. He writes some things on it. Is it offensive? No. He's exercising his First Amendment. So I'm not going to shun from the ideas of what's my opinion or what's on my mind. But I want to awaken the sleeping giant that there are those of us who can basically be cordial, polite, and entertaining. And then there are those of us who are shrewd, gargoyle-ish, and worship the same unpractical ideas maybe that goes on within your own minds because you're fed by a systematic environment of government that leads to lies and more lies and deception of all things that deal with our issues.
Thank you. Okay, now we will move to public comment. Adam Cohen, the AIDS Healthcare Foundation.
Good evening. My name is Adam Cohen. I'm the Director of Advocacy and Policy Research for AIDS Healthcare Foundation. Just as a fun, quick timeline, November 2013 is actually when we submitted the petition for the Health Commission. And May of 2014 is when we got, when the city clerk certified the 100,000 voter signatures, and then the LA City Council then adopted the creation of the Health Commission. October 2015 is when the commissioners were appointed, and then November 2015, so 1 year ago next month, is when they had the first meeting of the Health Commission. So I'd like to say we've come a long way, and of course, one of the goals, and as we've been talking about, is to have the health services plan to discuss the health needs of the city of LA. And of course, AIDS Healthcare Foundation is more than happy to assist in providing any recommendations for health promotion, for disease prevention surrounding especially STDs and HIV. Anything we can do to ensure that the LA City Health Commission fulfills its duties to attend meetings, publish health services plans, presents reports to the City Council, reviews representative samples of the county health services contracts. And just as we move forward, I actually really look forward to the report because I hope that it'll be used to make recommendations to the City Council surrounding really germane public health issues that are taking place. So that's what I wanted to share. Thank you.
Thank you. Armando Herman.
So you see, I brought my adorable UCLA bear. But behind the mask is an innocent little puppet. Some of you at one time were innocent until you engage in the environment of what politics or what politicians do to the community. They fuck it up. Haven't you seen the population of people on our streets? And not one of you is disgusted by any of that or appalled? Why don't you go to the council meetings and for one fucking minute exercise your First Amendment to speak about the horrible conditions that you see on our streets? There's no housing. Yet you're going to vote for HHH by Eric Garcetti, that homophobic fool. And what about the other measure, Measure M? Will you vote on Measure M? A half cent with unlimited timeline? That is absurd. To pay for what? More politicians get chauffeured around by their chauffeurs? Goddamn niggers, get a real job. Get a real job and stop being parasites living off the American people. If you want to have parasites in your community, keep voting on elected officials that are scumbags like Herb Wesson, who lies about where he lives. Read about it. And what about the other fool? I'm talking about the fool that continues to lie to all of you. 14 members of the city of Los Angeles. No housing for improvement for the homeless. Veterans are still on our streets. 22 die a day because there are no better conditions than the ones you all talked about earlier today from item 1. I haven't seen one embetterment or a constitutional embetterment to make America great again. Fuck all of you.
Okay, thank you. I'd like to thank everyone for coming out tonight, all the commissioners, the city attorney's office, city clerk's office, our sound person, who I definitely want to acknowledge for coming out every single month. Thank you, and I look forward to seeing everyone next month.
Yes, of course. Thank you.
Good evening. Welcome to the October